evening, everyone. Thanks so much for joining us. So I understand that some of you might be here for the first time this evening. So the idea of these Zoom sessions is that you can get a real feel for bariatric surgery and what we offer at Salford. We also have our team at Calderdale that also do bariatric surgery. So I know some people here might be from the North East as well. So they will do a talk throughout the year too. The idea is that when considering bariatric surgery, you should always be making an informed choice. So we hope from the different speakers we have that you get a real feel for us as a team, and also obviously the bariatric surgery and the two types of surgery we offer at Salford. So I will start my presentation now. Okay then. So right now you'll be part of a tier 3 weight management service, and once you've gone through the process with them and you're at the stage where their multidisciplinary team have said, great, everything's fine, let's get you referred over to Salford. Our team are very aware that these waiting times can be long, and at the moment it's around a year from referral to meeting our team because we're just so in demand, unfortunately. So you'll have the waiting list coordinator give you a call and say, we have this available appointment for you. It'll be always on a Thursday afternoon, and it'll be multiple appointments, and you'll be with us for up to maybe 3, sometimes longer, 4 hours. You'll have your bloods taken. You may meet our medical physicians depending on your history. You're definitely going to meet a surgeon, and prior to this we will send you some information that we want you to look at, things that hopefully will be a refresher and a bit more in-depth understanding. So there'll be some videos, there'll be some booklets to download, and there'll be a checklist just for you to kind of go through and understand what you know already or what perhaps you don't know, and then you can have a look depending whether you prefer to watch and learn or read and learn in the information that you get provided. The body of that email will also have a link for a Q&A session. So it's not really like this is a huge forum. This is a little tiny forum with people kind of at the same stage as you who are looking to proceed with surgery now, and they'll have met the surgeon or be about to meet the surgeon and the team. So it's much more individualized Q&A, and anything from the education information we send you, that's your kind of place to be able to ask you questions. The process often means that we're looking at surgery and we're thinking about body and mind. So we know that surgery is a physical tool that can help with rapid weight loss. But then long-term maintenance of that rapid weight loss and understanding what you're doing with surgery, it's very much body and mind. So we hope that during this time with your tier 3 weight management, you really are looking at yourself as an individual. They'll be looking at you as an individual, and if there's any kind of psychological side of things with food, which there almost always is, that there's things that you can be doing now to look at that and address that. Very often psychometric scores are sent to you, psychometric papers are sent to you to complete. That also gives our psychologist, who's part of our multidisciplinary team, a little a mini assessment, if you will, to see if a psychological assessment's needed. Very often they are. Most people have a psychological assessment. It's just thinking again about that mental toolkit as well as the physical toolkit that you're going to have, and they normally last about an hour and a half, so it's just something to be aware of. All right, I think I've covered everything on there. Oh yes, private provider. So very often, as you'd be aware, maybe with the very teams that you're with now, that private providers offer NHS services. So you're still very much an NHS patient, but our Oaklands Hospital, the team there that do bariatric and some orthopaedic surgery at their centre, which happily is just across the road from Salford Royal, they will do our bariatric surgeries for us. It is our surgeons, it's their lovely facilities, it's often a lot calmer and you have your own room, and we tend to find that very few cancellations ever happen there, which is nice from NHS centres where sadly there are a lot of cancellations due to what might be coming through A&E or bed capacity in the hospital. So when you come to meet the surgeon, the private providers will have their own conditions, as it were, for patients that can be transferred to their lists, and these usually are people that don't have too many comorbidities. So this is your history. So if you're on dialysis, if you've got problems with your heart, we're going to want to do your surgery at Salford because that'll be the safest place for you. They also like people to be a BMI of below 55 for ladies and below 50 for gentlemen. This isn't really a sort of a sexist thing. It's because of the way men and women carry their weight differently. And when our surgeons meet you, they don't mean to be rude, but they will look you in the eye and they'll quickly look down to your tummies, and they'll be thinking about where they're going to be putting their laparoscopes to do surgery. So for gentlemen, very often you tend to carry weight out front, and ladies tend to be a bit more pear-like or wobbly, as I describe it. So it's all about whether the surgeon feels they can safely do the procedure for you and get their kit through. So where it's a bit more complicated, again, we would want to do that here at Salford rather than at the Oaklands Hospital. So the day of surgery, you will come in, you'll bring all your medications with you. If you have obstructive sleep apnea and are established on a CPAP machine, and this is again something we look for before surgery with a sleep study at our centre if you haven't had one already, you will bring that obstructive sleep apnea machine with the CPAP machine with you. So the surgery itself is keyhole. So that means where your abdomen is, we'll make 5 incisions and we pop our laparoscopes in. We fill your abdomen with a carbon dioxide gas and then advance our kit so we can do your procedure nice and safely. There's a lot going on in that little thoracic region where we're going to be doing our surgery. So we do ask you to do a liver reduction diet prior to surgery, and we ask you to do the diet one rather than the liquid one, but our dietitian will do talks for you all around that as well. So the bariatric surgery, and I'll go into what those is completed, then the gas is released. So this isn't done in an exciting way. We're not jumping on you to expel that carbon dioxide gas that we filled your abdomen with. It literally, when I've watched the surgeries, it just kind of goes at the end. So little pockets can be left in. So that's just something to be aware of. Sometimes people can get gas pain after surgery, and that can be quite pronounced, because if any of you can remember the last time you had trapped wind, it really can feel quite awful, but that does pass. And not everybody gets that gas pain, but it's something to be aware of. When we've done your surgery, we will pass the dye down. So our team will make sure that dye goes down your esophagus through the stomach where we've done your surgery. And the reason we do this is we're just making sure that our staple lines are lovely and secure and exactly what the surgeon intended. And then, so when you wake up and you have that first wee and it's a bit green, don't panic, it will be from the blue dye. And sometimes you may even have a little spill as we've done it, so there might be a little bit of blue dye down. I haven't seen that for a while, but it has happened. The incisions themselves, most surgeons favour glue being the modern way to seal wounds afterwards, and others also like to use staples. So depending which ones you have, you may need a district nurse, which would be arranged at your discharge point for the removal of those clips or staples. And glue is easy peasy. You just completely ignore it. You don't cover it with any dressings. Your shower is normally pat dry, air dry, which you would do the same with those clips as well. But you can just completely ignore it, and then it's a nice little neat line at the end of it, and you may not even notice that a year or so on. Recovery, so after your surgery you'll come to our recovery area where they make sure you come around from your anaesthetic nicely. Sometimes there can be a little bit more pain, then we give you some morphine to help with that. They will also make sure that if you're nauseous that we can get on top of it with some antiemetics. So that is why when you've had bariatric surgery, we always want you to stay as an overnight stay, and then maybe even one more night, depending on how you're getting on with your pain, how you're getting on tolerating sips and fluids, which can be a bit more difficult if you have been sick after surgery from the general anaesthetic or any nausea. So we just make sure that you kind of the right side of any pain, and that you're able to drink nice and slowly and little sips still, but that you can get fluids down. And then you would go home hopefully the following afternoon, evening, and most of your recovery will be at home. So that's when myself and Chris will be checking in, making sure you're doing okay as well. There are always risks to surgery. So risks to bariatric surgery are similar to maybe like a lap chole, things like that. They're still major abdominal surgeries. So we try and minimize risks as much as possible. So clots in legs and lungs. So if you're on blood thinners or medications, we're going to do a bit of bridging or tweak those around so that it's safe for doing our surgery, but you still have the therapy you need. If you don't have any pre-existing conditions to do with clots or blood thinning, then we will actually give you what we call prophylactic, which is like a preventative measure. So we'll ever so slightly thin your blood with some injections. They're usually called things like tinzaparin and enoxaparin, and it just ever so slightly thins your blood, as I say, while you've been less mobile because of your surgery. We'll also put on some nice anti-embolism stockings. It's not one size fits all, so sometimes they're good, sometimes they're not a good fit, and we won't wear those. And then really the main thing for me is that to prevent this, that you're up and about and mobilizing as soon as you can. It prevents lots of things and it makes everything a lot easier with the weaning process too. So movement after surgery, even if it's just picking up your knees, twiddling your ankles, getting that gut motility going is really important. Anastomach leak or leak. This is a very rare occurrence after bariatric surgery, but it can happen. It's less than 1%. We do want you to be in the best possible place to be healthy after surgery in terms of healing, which is why it's really important, especially with the roll-wide bypass where we have two healing joints inside, that you are a non-smoker. It's not because we want you to be super healthy with the weight loss and then being a non-smoker, but it really does almost threefold increase risk of breakdown, of healing, of ulcers forming where in areas where the staple line is. So if you are a smoker, that is definitely something you have to address to be a lifelong non-smoker, not just for the day of surgery or the first few weeks after surgery. We'll come a little bit more back to the leak shortly, but as I say, less than 1% of patients, and it will mean a lengthier hospital stay. It's not an easy thing to heal a hole in your gastric area. So we will be looking after you, making sure that you're on the right side of healing, which means things like CT scans, barium swallows, so we can keep an eye on what's happening. It might mean return to surgeries where we can sometimes use what's called an endo sponge to try and heal that area. So it would definitely mean staying in hospital for longer, and it would mean having a feed through a different route that doesn't rely on your mouth. So that might be a tube in your nose to feed you while that's healing. So that's something to be aware of. Chest infection, wound infection, these things can happen a bit more commonly after surgery, less than 3% of patients, but again, most of your recovery is at home. So I want you doing those deep breathing exercises. They're kind of and a good huff, things like that every hour, just to make sure that little secretions that may have gone down into your lungs while you were under anaesthetic are lifted and they're not festering there and causing any kind of chest infection. The other thing is wound infection. So again, they're either glued or they're clipped, but if they looked red or angry or something yucky was coming out of it, and again with your chest, if it was heavy and you were coughing up something green or disgusting, anything like that could mean that you have got an infection. So once you're at home, it'd be straight onto the GP. Yes, it is an emergency because I've recently had surgery, and then your GP will either want to see you or prescribe you some antibiotics. It's just being aware of things like that, because if you're in the liquid phase, you have to say, oh, can I have the kiddie stuff please, ideally sugar-free, because we don't want you having big massive tablets either, and often antibiotics can be quite big. Ulcers, so I've briefly touched on that, tends to be an increased risk for smokers, but something just to be aware of. And again, we try and prevent that. So we'll give you something called lansoprazole, which is a proton pump inhibitor, which just means it dampens down the amount of gastric acid you're producing around those healing areas. So we actually put you on that for 2 years after surgery, and initially it's like a little tablet that dissolves on your tongue, so you don't have to rely on it going through your stomach while all of that's healing in the first few weeks. Bleeds. So when you think about where your surgery is, as we swallow things, it goes through our stomach and into our intestine, and there's lots of villi and tiny little vessels all around the anatomy and structures of our gastric tract. So when we put our staple lines through it, for want of a better word, it can be a little bit oozy, and sometimes the body will just clot it all off, and that's lovely. And sometimes you might get a little drip drip drip, and then it clots off, so then you can get maybe a bigger clot there. So sometimes when people after surgery, they might get they may vomit, they may and they might look at it and think, oh no, it looks a bit like there's blood in there, and that's usually just a sign that it has got a bit drip drip drip, and then it's clotted up and you're fine. And that's part of the reason we look after you in hospital overnight for the first night and make sure that those sort of things all right in themselves. If there was a more pronounced bleed and we were concerned, it's very rare, but it may mean that you need to go back to theatre, find where it is, make sure it's clotted off. Any kind of hematoma that's there, we can then evacuate and you can carry on healing as you should. Hernias, so because it's all the gastric tract and we're messing around a little bit with that anatomy, sometimes hernias can develop. We actually again try and prevent that. So when we change the anatomy for the Roux-en-Y, we close what we call certain defects so that loops of bowel don't try and go somewhere they shouldn't, which is essentially what a hernia is, a loop of bowel finding somewhere it shouldn't be. Sometimes that could happen with the laparoscopic wounds. It's quite rare, but it can happen. And all these things, you know, we would obviously investigate for you and then sort out for you. And all of the things that I was just talking about, the chest infections, wound infections, bleeds, hernias, things like that, less than 3%. From our national audit data, the mortality rate with this surgery is 0.038%, which is relatively low. The benefits, hurrah, because I've probably scared quite a few of you there, and that's not the intention, but every surgery carries risk and you do need to be able to make those informed choices. And the reason you're all sat here is because you're really considering the benefits of surgery and they can't be underplayed. So marked improvements, things that healthcare professionals might get super excited about, and you as well. Type 2 diabetes, for example. If you have type 2 diabetes, the gastric bypass, the Roux-en-Y gastric bypass is the absolute gold standard, as is the single anastomosis bypass. We'll come to the types of surgery we do in a moment. So yeah, so with type 2 diabetes, if you were newly onset, so diagnosed in the last 5 years, we would fully expect you to go into a full remission of your diabetes, and that can happen as little as weeks after your surgery. And then if you've had it more established over many years and perhaps you have to use insulin and things like that to control it, then we would expect that you would come off medications like that and maybe only need perhaps metformin to manage that. So it should be a less kind of sinister trajectory of the diabetes disease, really, and hopefully if you have a full remission, take you off that path completely. But we still advise your eyes and your feet are checked annually, just because you have had diabetes in your history. Sleep apnea, which we look for, so this is that kind of absence of breath while you're sleeping, so you always wake up tired because you just never get into a deep sleep because your body keeps saying wake up, take a deeper breath, and you never really get that lovely deep sleep. So lots of people who are waiting to have surgery or may have concerns around this, it's worth talking to your GP. If you snore, if you've got quite a big neck circumference, if you're always tired when you wake up in the morning, it might be worth asking for that, because the treatment for it, even though it can be quite invasive, it's got a CPAP machine, you have to wear a mask while you sleep, it really can change the quality of your life and your energy levels. So that's one that if you're already thinking, oh, that she's just described me, might be worth speaking to your GP about having a test before you come to meet our team. High blood pressure. I'm sure all of you get quite fed up when you go and see healthcare professionals and they go, well, if you lose weight, well, let's see. And that's the point, isn't it? So if you have high blood pressure and it is related to weight, then we fully expect again for you to go back to having a normal blood pressure. And it's just things like this you need to be aware of, because initially after surgery, we would absolutely say that taking blood pressure medications is essential. And just to note, after surgery, you don't have to have all your medications in liquid form, just maybe very big ones that we need to think about how you can have, but normal kind of most medications are the size of a 5p piece or less, and they're fine to take, and that does cover a lot of the blood pressure medications. So we would fully expect you to take those, but then as you're going through your rapid weight loss phase, if your blood pressure is now coming back under control and to a normal range, and then you're taking a medication that makes it low, you could end up getting a bit dizzy and faint. So it's just something to be aware of as you go through weight loss journey. Other conditions could be improving, and you might not need the same amount of medications, or if at all, any medications. Same for cholesterol. Fertility. So again, we know that there can be genuine kind of there can be fertility issues to do with underlying conditions, meaning that you can't get pregnant, and that's really difficult, or that you can't conceive. And if it's more, and we know that when people are obese, that actually fertility is worse. And you may have other conditions that make it hard, like PCOS. So rapid weight loss again can help, and you may notice that if you weren't having periods, you start getting periods, or that if you had periods before and they're a bit erratic, then you might start getting a regular pattern, and that is usually a sign that you are now more fertile. So for patients that don't want to have babies, and everyone really, especially in that first 12 months, when you're kind of going through the weaning phase and getting back to how you're going to be, you don't really want to be getting pregnant. So just be really careful with your contraceptive methods during your weight loss journey. Chronic pain conditions. So there can be a marked improvement in many pain conditions, but it's a little bit of an individual journey, because your gait, your posture may change. You may get aches and pains where they weren't before. It can sometimes feel like you're taking 2 steps forward and 1 step back when it comes to pain. And also there's some pain medications that are completely contraindicated after bariatric surgery because of the increased risk of disturbing that gastric area. Things like non-steroidal, so that's like ibuprofen, naproxen. So if you have a chronic pain condition where you're relying on those every day, then bariatric surgery is something that you also really want. You need to think of other pain relief that you might need to talk through with your pain management teams or your GP. So normally things that avoid the GI tract would be more suitable, whether that be topical gels or patches, or different kinds of medications that aren't non-steroidals. Okay, able to do more. I know that sounds a bit silly. I think most people are doing the best they can with whatever they want to get on with, whether, you know, walking, going to the gym, whatever activities, running around after kids, all those kind of things. But all those kind of things can get inhibited, especially the older we get, when we're living with weight issues. So for lots of my patients, the lovely feeling of just being able to do more, and you tend to lose weight initially, and people notice it quite quickly because people tend to lose weight off their face and neck first, and that does kind of ease things quite a lot. And another reason why things like obstructive sleep apnea go into remission as little as 7 days after surgery, and we're not always sure exactly why, because you haven't lost loads of weight then, but we do notice it tends to come from this area initially. So people do feel that they can do more, which is just brilliant. Reducing risks of all kinds of diseases that are associated, things like stroke, cancer, heart disease. Access to other operations. I'm sure there's many people sat here who have got, I don't know, maybe they need to get on a transplant list. Maybe they're trying to get IVF. Maybe they're, and if you do have either of those things, or maybe you need to have a curative operation because you have a cancer that's difficult to get to and you need that weight loss. They're the only things that can be expedited for bariatric surgery. All the other things that are also really debilitating and really hard. So this could be things like knees, backs, kind of chronic conditions where you really want to see that weight loss can help. So if you need a new knee, a new hip, and so on. To access other operations, you'll very often be told you need to have a BMI of 35 or below. So it's just something, again, to be mindful of with this. And as soon as you're kind of getting through that rapid weight loss and you're seeing your BMI coming down, that you're then knocking at the door saying, get me on waiting list, I'm only going to get smaller, so I need this next operation. And we usually say, depending on the urgency of the operation, 6 to 12 months or less, like as I say, depending how urgent it is. Mental health and well-being. So we do notice, and it's a few different strands on this. So yes, it's lovely to lose weight, and sometimes that can make people feel just absolutely wonderful. So that can improve your well-being and improve your mood. And then there is this element of satiety, so that's linked to the hypothalamus and the changes we make in the bypass and sleeve. So people do tend to notice that they just generally feel a bit brighter about things. So that's quite a nice side effect of surgery. And then again, medications for maybe you've had some things for anxiety or mood, and they work really well for you. So things like sertraline, quetiapine, mirtazapine, fluoxetine, citalopram, all these again essential medications, but they might need tweaking. So depending which surgery you've had, if we have the bypass where quite a bit of bowel is no longer being used for things, you may find that you actually need an increase in some things to get the same level. I don't know if I've got a slide on all the medications. I'll see if I come to it, but there will be a few changes that you and your GP need to be aware of, and any other respective teams that look after you. So let's talk about surgeries. We offer 2 types of surgery, a sleeve gastrectomy and a gastric bypass, of which there are 2 kinds of gastric bypass. So the sleeve gastrectomy is one that probably a lot of you have heard about. This is the one where we are going to make you a banana-shaped stomach, I would say, that is the diameter of a butcher's sausage. And the rest of your stomach that you're no longer using, and it isn't a neat, pretty picture like this is showing here. A stomach is essentially a carrier bag that we fill up with food. So the remnant stomach will be removed. And that's something that we always send off for histology, not because we're suspecting anything sinister, but it's just good practice to check any tissue that we take from a person. So we'll do that for you. And also one of the wounds that you have, the laparoscopic wounds on your belly, the one just to the left, that one will be what I call the working arm of the surgeon, and where that remnant stomach's pulled through. So it's a little bit wider, it'll be a bit more tender and sore, and there will be an internal stitch inside there as well. So as you can see, food will come down the esophagus into that stomach. It's not going to hang around for long anymore, so that gives it a slightly more malabsorptive effect, and then it's going quite quickly into small bowel. The sleeve gastrectomy is technically the easiest for our surgeons to perform and the least time on the table. The Roux-en-Y gastric bypass. So if you Google gastric bypass, the majority of what your search engine pops up is going to be about the Roux-en-Y. It's been around the longest. It's named after the French surgeon who first created it. And it is the gold standard of bariatric surgeries in terms of internationally the kind of the most weight loss that you could achieve. And it has a bit more of an effect on what I would describe as kind of metabolic syndrome of obesity. So these are things like type 2 diabetes, high blood pressure, hyperlipidemia, PCOS, things that can be associated, and the Roux-en-Y giving the greatest benefit of improvement for. So the way they do it is food goes down your esophagus, your food pipe again, and we're going to make you a little egg-shaped stomach. And then we're going to think of the surgeons always as plumbers when it comes to a bypass. We're rerouting and rejigging what you've got. So we'll give you a little egg-shaped stomach, and we're going to pull some bowel from further down and attach it to the bottom. And that is now where food travels through. The section that no longer is used for food is still there. It's the rest of your stomach and about 190 centimeters of small bowel. It all has a blood supply, still has a function, just no longer being used for food. And it's plumbed in further down. So there's 1, 2 surgical joints. So then everything that was all your gastric juices and everything that's usually fed into your GI tract further up, so that part that you're no longer using, that means the gastric juices and everything, which are kind of the green arrows, and the red arrows are your food. They will join and mix together so you can get kind of absorption of all your vitamins, minerals, nutrients, supplements, fat, sugar, and all the other things that will get absorbed. Okay, and then there's a newer surgery. It's not that new, it's been around for quite a while. But annoyingly, when you search this one, it actually has 4 names. single anastomosis gastric bypass, which is the one we tend to use, although you will hear some of our surgeons say the mini bypass. Nothing new about it. It's still a big surgery. It's still a big bypass, as it were. Then there's the one anastomosis gastric bypass and the Omega loop gastric bypass. And this is more to do with how they do this. So it's technically easier to perform than the Roux-en-Y gastric bypass. And rather than making two surgical joints, they're just going to make one, sort of where they kind of dissect and resect. So what do I mean by that? We give you a little egg-shaped stomach, so you can see where the food's coming down with the red arrows. There's your stomach. We've bypassed away the old section, as you can see, the larger section of stomach and the 109 centimeters of intestine. But then the way we've joined is we've done it in one staple line rather than plumbing in further down, which means gastric juices and food are meeting just as before and everything's getting absorbed. In less than 1% of patients, sometimes the gastric juices go around that loop, and rather than going down with the food and things, they try and go up, and that can be it can feel like quite bad reflux. So less than 1% of patients, and when we establish it's nothing to do with dietary weaning, because you can get that sometimes, a bit of reflux sometimes with that, we would need to convert it to a Roux-en-Y to stop that happening. So it's just another complication that you would add in, more to do with this type of bypass. Again, less than 1% of patients, but something to be aware of. So the one anastomosis is, I think I've pretty much gone through this. It's technically easier to do in patients with a larger BMI as well. So sometimes when we meet people that maybe have a BMI above 60, we want to get the maximum weight loss we can with one surgery. So this might be a really good option. Everything I'm talking about today, you will be looked at as an individual when you come and meet the team. So there may be reasons why we would think a single anastomosis would be good for you rather than a Roux-en-Y. There may be reasons we think a sleeve is a bad idea. Maybe patients that have something called gastroesophageal reflux disease, that can be more pronounced after a sleeve, again giving you horrible reflux. So we think of everyone as an individual, and obviously your research, your choice has weight as well, because if you kind of really keen on one over the other, as long as there's no additional risks or you're aware of a risk, if the surgeons are willing to take it, we will always try and do the surgery that you were hoping to have, but we want you to do that with very much open eyes and our expertise as well. So how does surgery work? So initially, yes, there is a restriction. You've got a brand new stomach. At first, you're going to think, oh my goodness, what have I done? I'm all swollen, I'm burping, I'm struggling to get my fluids in. And normally by day 4, the pain, if there is any, kind of settles away. That swelling's gone down, and the volume of fluid, that 1.5 litre of fluids we're asking you to have, including some nutritious protein, is much easier to get down. So you wean your stomach back to full normal diet. And Chris will do a talk about how you're doing this and the importance of why 3 regular meals, dedicated snacks in between, all those things are absolutely key, not just because it's the best way to wean, but also for long-term weight loss success of not regaining weight. Because some people might think, do you know what, I'm having a lovely time, I'm losing lots of weight, I really like my soups and I really like this soft stuff, it's all going down really easily. But if you don't get your stomach back to a normal diet, you'll notice that you can manage a lot more of that soft stuff, and they eventually become what we could describe as things like slider foods, which then can regain weight. So there's lots of things around the diet side of things that Chris, our dietitian, will do a talk with you soon as well. You will feel more full and satisfied after a smaller meal. I touched on that before. There's different things going on. It's not just to do with the surgical removal of some of your stomach. It's also to do with the metabolic and chemical changes that are happening with your brain as well. So it is a brand new system. So you have to treat it like that. It's like a rebirth. It's your baby that you're going to wean. So if you thought before, oh, I really don't, I'm not that keen on fish, or I don't really like Vimto, I don't know, whatever it is, it's all new. you might wake up and think, oh, I really, I don't really like cups of tea anymore. And I've always relied on my cup of tea every day, and I'm just not that keen anymore. So there's going to be lots of different things. Sometimes you can get taste bud changes at first. And there's often things that people comment on, things like water seems to go down heavy, but if you have a sugar-free cordial, that goes down fine. Or if you mess around with temperature a bit, you tend to find that you can manage more fluids if they're warm or very cold. So there's different things to you, but are common to kind of the community that have had this surgery. Influences the production of hunger hormones. So we know that there's a hunger hormone called ghrelin, and because of the change in your anatomy, again, you just don't have as much of it. So yes, you still will feel some hunger, but it shouldn't be pronounced. So for example, if you go on a diet now, you will normally find that there'll be times in the day where that hunger is just horrible and it's really, really difficult. You shouldn't have that with bariatric surgery. What some people get is sometimes like a head hunger. So they'll associate certain activities or certain things with food and maybe get a bit of a craving for that, for a certain type of food, but you don't tend to feel hungry as such. You work with it as in following the dietary advice. So as I say, Chris will go into that. On average, people will lose around 60 to 70% of their excess fat in the first 12 to 18 months. So when we say excess fat, we're thinking whatever your BMI is, and then we'll say BMI of 25 is kind of healthy. So whatever your BMI is to a BMI of 25, that is your excess fat. So losing 60-70% of that is what we would expect. And of course, we see people lose more. We sometimes see people lose less, and there can be different reasons surrounding that. It can be harder if your mobility is impaired, so you may not lose quite as much over the period of time. But then I have had patients who've had that, but because they've stuck with it and things have improved, they've actually gone on to lose more over a greater period of time. So there is always, again, nuances, as you are all very individual. I know before I was saying that all bypass boast the most. Through our centre, through the research we've done, in the first sort of 12 to 18 months, most people sleeve and bypass are losing similar amounts of weight. I think long term, it's really important that you get into the habits, because there can be instances of weight regain from 2 years plus. So medications, liquid medications to take home for 3 weeks, then back to tablets. Like I say, it's not strictly true. Some things you need in a liquid form just simply because they're too big. And it would only ever be essential medication. So even like things like the statin, that can be quite big. You wouldn't necessarily need that, if depending what you were prescribed it for. So we'll be very particular in prioritizing you getting your fluids down and weaning over tablets. So you'll only ever take essential tablets. And then painkillers, again, we've touched on that. So what I was saying before about naproxen, ibuprofen, those things are contraindicated forever. Obviously, if you had like a really bad toothache and you needed to go and get it sorted out, then having ibuprofen is a completely sensible habit, because it will work really well for that pain. But it's more to do with if you were taking something every single day. We touched on anticoagulation. So if you're already on things within your blood, don't worry, that wouldn't stop you having surgery, but we are more careful with how we prepare you and what you take afterwards. Antacids, so that's the one that ever so slightly dampens down the gastric acid, so we just promote you to have that in the first 3 weeks in a dissolvable tablet. Will medication change after surgery? So we've talked a little bit around that. So we were talking about diabetes. So for example, if you're taking drugs that lower your blood sugars and suddenly you're not really having hardly any sugar at all in your intake, we don't want you getting hypoglycemic attacks. So that's why very often you don't take any diabetes medication after surgery. Supplements, so tick, 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 yes, 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 both surgeries. Definitely with the bypass, because of the small bowel that you're no longer using for food, it is essential that you are really on it with your multivitamins and mineral supplements. You can start them 3 weeks after surgery, but you're not going to be depleted then. These are preventative measures. We don't want you depleted in something in a bad way 5-10 years down the line. So getting into habits of how you're taking your tablets, spreading them out throughout the day so they don't interfere with your meals, is something that you just work on from 3 weeks. So it doesn't mean that you have to have them all at once and then suddenly you find yourself a bit nauseous because you can't manage the next meal. It's just a journey of getting them in those sort of first 6 months to a year into a really good routine. We'll help you with that. We'll help you with your GPs as well, so that they know what to give you and so on. And as I say, that's just not a cause of anxiety. You'll have strategic calls in with me, and we're available by phone as well, so we can always help you along with this. But it's just something to get into habits with around that sort of 6-month mark. Hopefully you've got everything and you've got them all in, so don't worry at 3 weeks if you haven't been prescribed and you haven't started taking them. Nothing bad's going to happen. There's certain things you need to know with some of those. So again, that's why I do certain phone calls at certain times. So iron and calcium, for example, if you have them together, nothing bad happens, but they compete for the same absorption spots. So you only get a little benefit of both. So you may as well not bother taking them. So it's knowing to separate those by 2 hours. If you take things like levothyroxine, that doesn't really like iron either. So you need to make sure you have it a good half hour away. So little things that we'll check for you as well. Pregnancy after surgery. So I know I do touch on all these things as I'm going along, but yeah, for some people this could be the main reason you're having surgery, so you want to get going, and we ask you to wait 12 to 24 months. A baby is wonderful. When you're pregnant, it's basically a parasite. It's going to take everything it needs from you, so you want to be in the best place possible to be able to give it. So yeah, being established with your regular eating pattern, your and so on. If you got pregnant within 2 years from of having surgery, then do get in touch so we can just give you some advice. But beyond 2 years, it's like you're just the same as everybody else who's getting pregnant. You don't need to make any special allowances. If you were on lansoprazole as an antacid and you were pregnant, you would switch that to omeprazole in those first 2 years. But again, all these things we just put here because we want you to have an awareness of it. And if you got pregnant, you get in touch anyway. So we like to phone you in the first few weeks after surgery, so that I will give you a call, Chris will give you a call. Then we try and get follow up around 6 weeks and 16 weeks. We are getting lots of surgery done. They haven't doubled our theatre capacity and they haven't doubled our staff, but we are getting as much done as we can, especially using the Oaklands as well. So a lot of our clinics and people like me, there's not enough of us. So that 6 and 16 weeks can sometimes end up being 3 months and 6 months. It just depends on the peaks and troughs of how much surgery we're getting done. So again, you'll have our emails, our numbers. So if there's any concerns, you can reach out to us anyway, but we'll also put in follow-up appointments for you too. And then, unlike any other service I know of, at Salford, we will offer an annual review with bloods, which your GP will be really happy about. And it's quite nice. It's just a really nice way to keep touching base, see what else is going on. We'll also expect that kind of commitment back to, which I think the very fact you're all here is because you're learning and you're wanting to know and you're wanting to understand if this is for you and if it's going to work for you. So you're all committed just listening to me right now, so thanks. Maintain your weight from the day you see us. I think this is a hard one, and I think, to be honest as well, you're not here because weight loss was easy. You're not here because yo-yoing isn't something that's been part of your life. So I think when you are going through this process, sometimes it can be a self-discovery and it can be a bit of a self-awareness, a really good sort of learning tool of things you need to change, and you might just naturally lose weight like that. I know lots of people that come off Diet Coke and lose so much weight, but there's things you can be doing now, part of your tier 3 weight management, so that you're in good form. And then you've got this year where basically these forums where you come and catch up with the team and see us is kind of where you're at. So it's just trying to keep those good habits. And then when you meet us, there's some people that are so worried because I think, I know I've put on weight since, and of course if it's a massive amount of weight, there might be some concerns, but we don't expect you to be exactly the weight. It'd be lovely if it is lovely if you've lost some more, but then we do see little difference, and I don't want anyone worried or concerned about that. We are a bariatric service, so we completely understand that you're not coming to us because weight loss is easy and easy to maintain. To attend follow-up, it's really, really important. Even if you're doing everything right, your textbook, you know it all, it's just nice to hear that you do know it all and you're doing everything right, and that we can monitor you and make sure that you're feeling happy and content with everything you're doing. Using this time now and everything I just said applies. Sticking to our recovery diet. So there's lots of different information out there about bariatric surgery, but our recovery diet's it's good, it works. So we want you to stick to our recovery diet. Not like kind of some of the crazy ones that are out there. The importance to mobilize as soon as possible after surgery and stay mobile. As I say, just kind of whatever you can do, and then whatever goals you may have, mobility and moving and just the very basics and building that up. There might be things that you're already doing but you wish you could do more of. It might be as simple as you know you've nailed all your breathing exercises and setting yourself little goals when you get home. I'll go to the end of the road and come back today, or I might go around the shop tomorrow, and so on and so on, and building things up. Just really important to recovery and then long-term success as well. Hopefully you'll ever more be building on activity that you're doing. When can you drive? Check with your insurance provider, but most people, most surgeons will say that you could drive 2 to 3 weeks after surgery, and that's when we also would expect you to be able to go back to work. We do a bi-monthly virtual and face-to-face support group. So we're changing things a little bit how we're going to do it. So we're going to have a pre-op support group once every other month, and then in between it will be the post-op support group, and then we'll merge now and then so that you can get the benefit of meeting patients that have had surgery as well, and they can have the benefit of thinking, I was that way you were. But let me tell you a few things that are useful. We like doing things with the sessions on things perhaps like what we wish we'd known, things that may come up that we don't always think of as healthcare professionals, and those sessions are really interesting and informative. People feeling quite cold with weight loss, so time of year when you have your surgery can be quite important to how cold you feel after, and things like what's another one that's on, being able to hear things going down, being very much more aware of fluids and noises, and that doesn't always stay, but it can. For initially you can hear things in perhaps a way you didn't before. So yeah, support groups are really useful, and we do it in such a way that you can do it like this, where you kind of a fly on the wall, but you can get active in comments and Q&A. But for post-op, I think it's quite important to have that face-to-face element, so we offer it face-to-face as well, with one of our team being on the virtual side. So if you can't make it face-to-face, or you just want to be a fly on the wall and listening to what's going on, you can. Right then, so I will escape from this and we'll have a little look at the Q&A. So I know I've got my colleague here from More Life as well, so I don't know whether there's any questions there. Hi Stephen, nice to have you back. Whether there's any questions there that you've come across yet that I could start with. I'll pull some up as well.
I'll pull some out for you, Jodie, and ask some. If I'm a little bit out of breath, I've just been walking on the treadmill, so forgive me.
She was just saying before she's got a walking desk. I've never heard of this. I think this sounds amazing.
It's good, but you can only do certain tasks on it. Okay, so let me have a look.
Yeah, so going back to the gym after surgery, so 2 to 3 weeks is what we'd say is sensible for kind of like just easing back in, getting to where you want to go. The gym can be a brilliant place. You don't need to tell anyone what surgery you've had, but it is worth saying that you've had abdominal surgery, so you just want to do some cardio. We don't really want you doing weights, rowing machine, like those kind of core activities or contact sports. So swimming and cardiovascular stuff, great. The rule is if there's pain, you stop. Okay.
So somebody said they've been diagnosed with cirrhosis. Are they still eligible for surgery?
Diagnosed with what, sorry?
Cirrhosis, I'm assuming of the liver.
This is a really tricky one. So we have to worry about things like varices, because that can be a really, it can bleed a lot. Varices bleed a lot, and then just we don't really want to go near them with anything that could make that a really difficult surgery or unsafe surgery. So when it comes to cirrhosis of the liver, it's from you really want to speak to your liver doctor, because we will if anyway, but it's just worth saying I'm considering bariatric surgery with my liver disease. What is that something that's realistic with surgery and so on? Because our team will write to your hepatologist and so on, and your specialist in that area, as they would for many conditions, just to be sure that team are aware you're thinking about this surgery, and also what extent the disease is to whether or not it's something that we just really couldn't do.
Thanks, Jodie. So the next question is, so somebody said, so am I right in understanding that women need to be 55 kilograms before they can have surgery?
No.
Yeah.
BMI. So you can have bariatric surgery, and we want to make it as safe as possible. Private providers, I presume because of how their insurances and their reputations work with their private work, will have quite tight guidance for us when we use their premises for who we're allowed to send to them. So they say for women, you would need to be a BMI of 55 or below, so 54.9, and for gentlemen, a BMI of 50 and below, and not have comorbidities where we would say, no, you're on dialysis, you need to have it in our main centre, you've got a heart disease, anything that where it's a bit more interesting and you want the benefit and expertise of all our other colleagues in the hospital should we need it. So if there's not too many comorbidities and you're a BMI below 55 for ladies, 50 for men, then your surgeon will discuss this with you, and that you should be able to have an option of going to the Oaklands Hospital, where the surgeon you meet on the day of clinic won't necessarily be the surgeon that operates on you. And that's pretty much true across the board with the way the waiting times can be, where we do try and do surgeries in a more chronological way, so that different surgeons may be the person doing your surgery on the day.
Thanks, Jodie. So somebody's asked, what's the liver reduction diet? I know you're not going to go into it in detail, and I'll pop Chris's video on.
Yeah, so Chris is my colleague who I work with closely at Salford, and he is our dietitian. So a liver reduction diet, so if you think about that thoracic region I was telling you about before, you got your stomach, then you've got this whopping great big rugby ball of a liver, you've got lower lobes of lungs, your kidneys come higher up, you've got a bit of your heart, you've got all your intestine, your diaphragm. There's so much going on in the thoracic region where we want to get to safely to do your surgery. So first of all, blowing up the area with the carbon dioxide gas helps, but shrinking your liver down does too. So your liver, if you all think about what a liver looks like, it's kind of squishy. When we do a liver reduction diet, we're targeting fluid. So we're literally kind of making it shrink. So the last 4 days of a liver reduction diet are absolutely essential. We always want you to do 2 weeks of it, and sometimes depending on where your BMI is or how rotund you are as well, whatever, from being eyeballed by our surgeons, they may even ask you to do it for 3 weeks. So the liver reduction diet, you don't need to worry about this or even think about it yet. When you come to meet the team, you're going to get the videos, it's going to have it in written form and talking you through it. So they're things for the future, but yeah, that's definitely something you do 2 weeks prior to surgery.
So I've popped that the YouTube video in the chat so everybody can watch that if they want to find out more. How would surgery affect somebody who suffers from diverticulitis or diverticular bowel disease?
Yeah, so diverticulitis can be a tricky one because you tend to always have irregular stools, don't you, and that pattern. And at best, it will be the same after surgery. It might be improved by the types of food you're having. But yeah, it's not a contraindication or irritable bowel syndrome. Things that might be would be more of autoimmune diseases of the bowel, which is more ulcerative colitis and Crohn's disease. Again, because of the nature of that disease, we probably wouldn't want to do bariatric surgery.
So somebody's asked, is the odd cigar once or twice a year classed as a smoker?
No.
No worries. if you're already on medication, do we need to get that in liquid form after surgery too? So I know you touched on that, but
yeah, I think I'll probably change that in my on the video. Some things need to be in liquid just because they're too big to take, and only things that are essential. So for the most part, you can snap it, or it's already less than a 5 pp. So no, you don't need to get everything in liquid form before surgery. There might be some things, but our pharmacists will look at that and normally send you home with the supply where we can. Supply issues sometimes mean it's easier to get from your local area than the hospital pharmacist, so we just see. But yeah, it's looked at before. But I very rarely give anyone anything in liquid form now, because sometimes that preparation can be really not very nice. The only thing that I would say is brilliant is Calpol, because it's thin, it's sugar-free, it goes down a treat. Whereas the issue that the NHS have is thicker and gloopier. Some people are fine with it, but I think that it's worth having the Calpol or raising the kids' supply if you need to for pain relief, because paracetamol is actually a really effective pain analgesia for surgical pain. It works on completely different pain receptors to morphine, so you can add in morphine if you're having really severe pain, and it doesn't mess around with your bowels. So sometimes codeine and things like that can make you a bit constipated, and when we're really keen to get gut motility going, we don't really want pain relief that's slowing it down again.
Thanks, Jodie. So Neil has said, are ex-smokers, so they've had 15 years of non-smoking, at the same risk of I can't say that word, anastomotic leak?
Yeah, so no. So it's very much about what you're doing after surgery. So no, if you've been a non-smoker, fantastic, stay a non-smoker. And if you're a non-smoker now, don't start smoking after. But yeah, it's very much to do with smoking after surgery.
There's quite a few questions about sleep studies. So just generally, what are sleep studies and who refers you for them?
Yeah, so I saw somebody saying, oh, I think I might have this. And my GP said that they wouldn't necessarily refer you. So a GP may use some scoring systems on you that allows them to be able to refer you, and just nothing to do with bariatric surgery, just refer you because they're worried that you may have obstructive sleep apnea. So obstructive sleep apnea is basically you're asleep, your body's trying to go into a deep sleep, but because of whatever the driver is for your obstructive sleep apnea, which is usually weight, your lung expansion and that exchange of gas and oxygen that should be oxygen and carbon dioxide that should be going on in the lower bases of your lungs, is for whatever reason isn't happening in the way it should do. So your body's saying, we need more oxygen, or we need to get rid of carbon dioxide. Wake up, breathe deeper. So you wake up, but it's and then back into your sleep again. So this could be happening all night long. This could be happening, every other minute. So it just means you don't get to go into a deep sleep. You stay in this kind of REM mode. So when you wake up, you're not really, it's a little bit like when you have a newborn, you're so attuned to them, every movement they're doing, everything else, you're never really sleeping deeply. And that's a little bit like having obstructive sleep apnea. So when we discover this, we can establish you on CPAP, which can really help open, it just kind of stents open those lower bases, so the gas exchange is happening properly all the time. Not everyone can tolerate it. It's a weird to sleep with something in your face, but that's what you would be doing. But we look for that always. So I'm sorry if the GP if you think you have this and the GP is like, oh, we can't, we don't think you have. Maybe they've measured your neck circumference, maybe they've done something called a stop bang or an Epworth score on you, and they're actually, no, don't worry, we don't think you have this, so we haven't got the funding to be able to send you for it. Like, oh, okay, then that's fine, and then we'll double check it when you come to meet us. Okay.
Thanks, Jodie. So there's a couple of questions that are quite similar. So can the stomach be stretched after surgery, so from overeating? And if so, does that mean that weight gain is possible after surgery? And what is it like comparatively to not having surgery?
So it's difficult to say, because it's a very hard thing to, so for example, I've had patients that maybe have been coming through the service, maybe they've had surgery elsewhere, or they've got so far down the road and they're worried that they had a bypass when bypasses first came out and they didn't really know what they were doing with it, and now they feel like they must have stretched that little egg-shaped stomach because they don't really have any restriction. It's really hard to measure it. You can get scans to try and have a look, but it's hard to measure that capacity. As I say, it's always like sort of like an empty carrier bag. We don't really want you to stretch out and stomach, because it won't be exactly the same as your old stomach, because it's a stretched out stomach. So yeah, it's really important after bariatric surgery that you understand how to use it safely, the regular eating pattern, that of course if you overeat you're probably going to feel quite uncomfortable, but then if you're regularly overeating by a little bit each time, you might be able to stretch it out. If you're going to have fizzy drinks, again, that gas that can also have that effect as well. So yeah, I think being really attuned and really prepared for your small portions, your regular eating pattern, understanding that it's a weaning process to solid food, so that you're not just stuck having lots of side of foods that go through. But in terms of stretching that stomach, I couldn't tell you exactly what that stomach would look like. It would be a little bit of an alien stomach because it's stretched out from being a little egg shape. So yeah, so that's something that can happen, but absolutely is what we're trying to avoid. So again, when you go in through this process right at the beginning, there is always a psychological element to food, and weight, and getting to a certain weight. And that exploration is really important. So when you're part of weight management services and they're saying, oh, have you got any kind of binge eating disorders, or have you got any emotional eating things that you're worried about, you might think to yourself, no, not really. But if they're offering any kind of like group sessions or any kind of psychology support, ask for it. Just say, well, I'm here and I'm quite big, so I probably have got things to explore, because that side of going into surgery, it's quite difficult to get proper support after surgery. Even in the service where I have psychologists I can refer to, I could speak to someone and then they'll say, oh yeah, we'll put it down, but our waiting list is a year. And I'm just like, but I want someone to speak with them now. So I think being that self-aware going into this is really, really important. And while you've got services that have psychologists or psychological elements to it, take it, because you just can't, it's so hard to get proper psychological help through the NHS. So while you're in a service that has it, do access it. It won't hinder your advancement, it will only help it.
Thanks, Jodie. So somebody else has asked, if they become pregnant whilst on the waiting list for surgery, will they be removed from the list, or can they remain on the list?
So I sent out emails. This is my lovely colleague Shirley, and I personally want to just stick a pin in your journey and then take the pin out. So just get in touch with me. We would ideally wouldn't want to discharge you, because we don't want you to have to go through waiting times to come back in. So there's normally ways that I can make sure that you stay with us. And then once you're postpartum, you can come back and meet the surgeon, and then we can think about realistically when you go ahead with surgery again.
So can I have IVF? I need the surgery to get to the weight I need to be. Would I be prioritised if I need IVF?
So if you have gone, so say you've for whatever reason, you and your partner can't conceive. When you go to fertility clinics, sometimes they may go, well, just lose weight, try, see if you can get pregnant. Well, what if there's a genuine problem with either you or him? Both of you would be tested for fertility conditions. If then, under a specialist centre, you were then told, I'm really sorry, you can't conceive naturally, you need to have IVF, but you cannot be put on the NHS IVF programme because your BMI is this and it needs to be 30. They say BMI 30 for IVF treatment. So having realistic expectations. So it wouldn't be fair to say to a woman who's 60, or you need to be a BMI of 30, have some bariatric surgery. You may never get down to 30. So it's kind of understanding where you are and how realistic that is. And obviously IVF NHS criteria is again really strict. If you already have a child, you wouldn't be able to go on to that. If you're a certain age, you can't go on to that. If you're a certain BMI, you can't go on to that. So the answer is, as long as you've already been through that and they have said yes, you know, there is a fertility issue and the only thing now that's stopping you having IVF is your BMI, then you tell the people ABL at More Life and they will send your referral through early, and we'll treat that as more urgent to give you the opportunity to have a child.
Thanks, Jodie. Is there anything in particular that would mean that you need to be referred to a psychologist after you've had your 4-in-1?
No, most people, because in weight management services there may be people where there's been, I don't know, whatever issues have gone on, and they've had some therapy around binge eating or mood and food or emotional eating or these kind of things. Not more serious things. Sometimes people have to step up a bariatric program to do an eating disorder program and then step back in. But all those things should be identified really before you come to meet us. And then when you have the psychological assessment, it doesn't happen very often, but sometimes there may be therapy sessions that are needed just because something's been missed, and that's usually quite mutual anyway and wanted. So no, most people have a psychological assessment. Just it's more to do with just talking through where you were, where you are now, and where you want to be, and using surgery as that tool, and having that mental toolkit as well. So it's usually a bit, again, it's an assessment, but it's a useful one for you to have that self-awareness going into it.
So a similar question, does having a psychiatric condition like bipolar stop you from moving forward with surgery?
No, not at all. It's really important that with psychological conditions that that you are engaged with services. It may be that you've been engaged with your services and now your GP manages your medications. Whatever it is, it's just as long as you've got good support, that your team that looking after you are understanding that when you go through weight loss, you might need a bit more of this, or depending which surgery you've had. Some people are on lithium. Lithium is a really important one to look after surgery, because things are going so quickly into small bowel now and getting absorbed in a different way. Lithium levels can be toxic and they can affect your kidney function. So again, getting levels like that and having your psychiatric nurse or your psychiatrist to know, as long as people have got well-managed conditions, and we haven't got any concerns, then no psychological conditions shouldn't stop you having surgery. There are some psychological conditions that are really difficult to know about easily, and sometimes, again, that level of self-awareness coming in is really, really important.
Thanks, Jodie. Nazir has asked, are there any foods that you absolutely can't have after surgery?
So anything that's too sweet, too greasy, or too starchy, mainly because they cause dumping syndrome and they will sabotage your weight loss.
Perfect. How long does surgery take?
So surgery itself, so for the sleeve gastrectomy, in terms of the actual performing that surgery, maybe half an hour, 45 minutes, but the actual time in the theatre will be a lot longer. So we normally book you a good hour and a half slot, just because of the anaesthetists doing their things, everyone else doing their things, get time coming round and all the rest of it. The technically most difficult surgery is the roll wide bypass, but all our surgeons are very skilled, but that one we book out usually an hour and a half to up to 2.5 hours. And the one anastomosis bypass, or the single anastomosis bypass, is again technically a little bit more easy than the roll wide, but takes longer than the sleeve.
There's quite a few questions about Saxenda. I don't know if you want to touch on that.
Not tonight, sorry guys, it's just not something offered. It's not something offered easily on the NHS, as I'm sure you're all aware, but it is a whole different topic in itself. Sometimes, I know there was a few questions and I didn't hear anyone mention balloons or bands. No, we do not offer those as a primary surgery for weight loss. Where we might have patients who have a really high BMI and we need to get them down so we can safely do surgery, we would have perhaps used a gastric balloon in the past with varying success, and they're not easily tolerated, but that could help people lose a little bit so that we can get in and do a safe bariatric surgery. And we may use that now, the Saxenda, which is now Wegovy, is the newest generation, so we might use Wegovy injections to negate the need of a gastric balloon, but it's still a very grey area. So weight loss primarily achieved just with Wegovy or these injections still isn't widely available, even through tier 3 services. They were trying it, you were trialing it, weren't you, at one point, and I think the funding got pulled for that. But obviously we're knocking at their doors because this is a really exciting progression for weight loss.
There was a national shortage, so we couldn't provide it. I think the same for More Life as well. It's a bit of a struggle. Sorry.
I was going to say there's quite a few things around the sleep study. Don't over worry. Your GP could refer you But if they can't refer you, actually, I know waiting times at Fairfield are just ridiculous. You get sleep study fairly quickly from meeting us. It's usually around 6 weeks. So you'll definitely get those sleep studies done if you need them when we meet you. If you've been diagnosed with sleep apnea and you're on a CPAP, established CPAP means tolerating CPAP, that you're on it, you're using it, and it's working for you. And for example, the Oaklands Hospital, they will accept patients who have obstructive sleep apnea, but only if they are established on a CPAP machine. So again, it's just another kind of safety element, because it's just allowing that good oxygen and carbon dioxide exchange.
There's quite a few questions, Jodie, about hernias. So I've had a hernia that's been repaired. Is that going to make a difference to surgery? And then, if you, on a similar note, quite a few questions saying people have had multiple surgeries on their stomach. Does that put them at higher risk, or are there any complications that they should expect due to that?
Yeah, so again, if you've had surgery on your abdomen, it doesn't mean you can't have bariatric surgery, but we'll probably go through varying options, so that when we go to do your surgery, if we find adhesions, which is basically scar tissue that's quite sticky, and it's quite a skill just getting and dividing those adhesions to get to where we want to do surgery. So depending on how much time it's taking, depending on how things look inside, they may say, let's do the sleeve gastrectomy. It's going to be the safest option. We just want to get in, do what we need to do now that we've been here an hour or two doing these adhesions, getting through these adhesions. So scar tissue can make things more difficult, but we still do our surgeries. It just may be that we'll say, well, look, if you really want the bypass, we'll try, and the single anastomosis might be the better option there. But if we can't do that, then we'll do a sleeve. So it's really important you research all the surgeries, because there may be reasons technically why they would do one over another on the actual day. Someone saying, what's a 4-in-1? That's when you come and meet the team. It's not really a 4-in-1. I think it was kind of accounting for 4 appointments in one day. But as I say, those appointments are kind of a little bit different now anyway. So you'll definitely meet a surgeon, possibly a medic as well, have your bloods and weight and things like that done.
Somebody asked before, is there a reason that I can't find the question, but I'll try and remember it. Is there a reason that they can't have a spinal block done instead of a
Yeah, I have seen, well, I haven't personally seen, I've been to conferences where there have been centres doing this, not so much in the UK, but no, it's not something our anaesthetists do. All surgery is done with a general anaesthetic.
Sorry, I'm just trying to find some more questions.
No, fine. You don't have an endoscopy before surgery. We may do that if we had issues around reflux and gastritis and we wanted to look and rule something out, but we would not routinely have an endoscopy before surgery.
Sorry, there's lots and lots of questions.
No, don't worry, I'm having a read
up. So somebody, I'm not sure if you touched on this before, Jodie, but somebody said if they are diagnosed with sleep apnea, how do you get the CPAP machine?
So if you're just diagnosed with obstructive sleep apnea, there's 3 kind of classifications: mild, moderate, and severe. Moderate and severe, you would then have a respiratory consultant or technician appointment where they would explore using CPAP to help that, and then you would go on what they call a CPAP trial, where they monitor it all with you and make sure it's okay and the mask is fitting well, that you can tolerate it and everything's going well with it. So you may get a diagnosis of mild obstructive sleep apnea and not need one at all, and mild obstructive sleep apnea can go to the Oaklands as well. But moderate or severe obstructive sleep apnea, which is a more definite diagnosis requiring treatment, which is the CPAP machine, you would need to be established on that. If you had obstructive sleep apnea that was moderate or severe and you couldn't tolerate CPAP, because not everyone can, that's absolutely fine. You just proceed for your surgery at Salford.
Thanks, Jodie. Somebody's asked, I've seen a surgeon and I'm waiting for surgery, but my knee replacement and surgery might coincide. Should I wait for the knee replacement, which actually makes sense, or go ahead with whatever comes first?
Yeah, I think in this world, it would be lovely to go, yeah, have some more weight loss before your knee replacement, but it's so painful. And if you've managed to get there and they want to do the knee surgery on you, then having that and then the bariatric surgery so many months later, all that's going to happen is the weight loss is just going to make things easier with your new knee. So I think whichever, in the way things are right now, whichever comes first is sensible.
Surely. So another question here. So if you've got issues with food, so like disorder or disordered eating or an eating disorder, so things like binge eating, food hoarding, hiding things when eating, will you be taken off the bariatric list, and will you be referred elsewhere, signposted elsewhere?
Yeah, so if you know this is you, you should absolutely tell your team right now, because it's just not something that works with bariatric surgery. You will almost, unfortunately, sabotage that surgery. So understanding that side of food disordered eating, so the investment, the commitment to that kind of therapy would be such a change for you in such a positive way, and the bariatric surgery will then only complement what you've achieved with that. So then you're ready for bariatric surgery. But yeah, not the other way around, because it's just, it just doesn't work so well. And then people feel like, oh, I had that opportunity, now I've gained weight, and it's just really hard and really sad. So no, it's definitely something you want to do with first. So if you're already on a tier 3 weight management program, talk to your team about that, and they can assess the level of that, whether that's something their psychologist would deal with, or whether that's something that would need like an eating disorder referral, and then you can get those things underway. It's always a journey with bariatric surgery. Waiting times are long, so there is time to do all these things, and it's definitely worth it, because you just want to do this once and feel like then you go off with your weight loss and everything else. You don't want any other factors that are going to sabotage it.
How long before surgery does somebody need to have stopped smoking?
Oh, it's a difficult one. The anaesthetist will always say you should stop smoking 6 weeks prior to surgery, but so very often, if you're a smoker and when you come to meet our team, we'll do some checking calls, make sure that you're okay, because sometimes you kind of need that light at the end of the tunnel to make massive life changes like that, because it's so addictive and so difficult. So a lot of people through the process, and some people still hold on to the kind of idea that, oh, if you smoke and stop smoking, you put on lots of weight. So I get why people will find this really hard. It's not an easy thing to stop smoking. So I think sometimes when you know you've got that appointment date, that's your green light to get, if you've not already been cutting down leading into it, that's a good time to stop before you meet us. And then if you haven't, it doesn't mean you can't have surgery, but we can't proceed you for surgery until you are a non-smoker.
And we've got a few people saying they need to leave, Jodie, so I just want to remind people to complete the satisfaction survey when they get their email through, and I'll pop the link in again now.
Yeah, please, just for your attendance.
Your attendance, and helps us to keep the sessions relevant for you.
Yeah.
And
And
there's
hernias, again, we can do bariatric surgery, so that you can go on and have repairs for hernias. If you've got a hiatus hernia, which is right by our surgery and we see it, we'll do it at the time of surgery, but if we won't go looking for it, so it will always do your primary surgery first.
I've lost your face, Jodie. I can't see you. There you are. Can you see any to pick out?
You don't need to take laxatives before surgery, for anything like that. That's fine. You'll be doing liver reduction going in, so it's not a problem. Oh, that's a good one. So people sometimes think, normally when you enter a weight management program, you're a certain BMI to get on it, and then you do really well with it, and you're like, great, I've stopped drinking Diet Coke, I haven't got any disordered eating, I'm in, like, everything's coming together, and I'm actually losing a really nice amount of weight. When you carry on your journey, do not step off. If you want, bariatric surgery, if you definitely know you don't want it and you're happy, great, but I would probably stay on the program. And then when you come to meet our team, depending on what your weight is then and where you're at then, you can make that decision. We wouldn't look at you and say, oh, you're a BMI of 32 now, are you sure you really want this? We might say something to that effect, but we certainly wouldn't turn you away and say you can't have surgery. Because sometimes the nature is you could have a really, really good run and then it might come back up again, or it might be that you're having a really, really good run and then the bariatric surgery is just going to complement it even more and it's even safer now. So yeah, so no, don't worry, whatever weight you lose, we'll just reassess it. I just would advise that you don't step off, come to the appointments and then make that choice if you're going to go ahead or not.
Wesley's asked if the talk from last month will be posted on YouTube. It will be. Our content creator has been off on holiday, so that'll be posted.
Mr. Alcafaf's talk. Yeah, he's actually done. You'll already have, because part of the reason that we're going to move these sessions to every other month is because we've got quite a good archive now of videos of all of our team doing the talks. So we want to keep it fresh and relevant and have somewhere for you to touch base. So we're definitely going to be keeping these sessions going every other month.
There are actually 35 videos on there now, Jodie, 35 sessions that we've done.
Yeah.
So lots
So
and
yes,
lots of
Mr. Alfast's probably on there at least twice.
I think he's done 3. I'll pop the YouTube channel in the chat as well. So if anybody wants to kind of have a look and go over anything that they've missed, then it's there for you to have a look. Oh, somebody said that they're due to have surgery soon. Can they have protein yogurt in the liquid stage of kind of post-surgery?
Oh yeah, we're a bit spoiled. There's loads of stuff out there now that's going, oh, protein this, protein that. So it's quite nice because there's lots of things you can have and try. But yeah, yogurts in the liquid phase need to be not the thick skyr ones and quart ones, which are the protein ones. So you can just mess around with them. So you can get milk, mix it with some of your yogurt, maybe with some frozen mango in there, and you've got like a nice little breakfast shake. So that kind of thing you can do. And if it's a more runny consistency yogurt, you can very slowly have that as well.
Well, it's an interesting question. So somebody said, what happens if you've got a gastric band in situ? So it's from 25 years ago and it wasn't successful for various reasons.
Yeah.
Manipulations with the actual bypass.
We have to remove the gastric band before we can then proceed with the bariatric surgery. Then we would have to wait at least 6 months between the surgeries. And the commissioners say that you have to have ongoing weight management during that time to prove, I don't know what they want to prove. It's a bone of contention. Our MDT are trying to shun this, but actually in reality, if you have a gastric band removal, we're going to want to wait 3 to 6 months before we do your primary surgery after that anyway, for things to settle down. So yeah, so if you have a gastric band, that's fine. It's just there's a bit, you need one surgery then the next surgery, so it can be a longer path. Okay, and it usually will all be done at Salford, well, maybe the gastric band removal at Oaklands, and then depending on your surgeon, whether or not you would then have it at Salford, or when I say depending on your surgeon, I mean depending on the surgeon when they've done the removal, whether they think, oh, actually everything looked quite nice in there from that gastric band removal, we can carry on with our surgery here at Oaklands. Or they may go, that was really hard to get out and it was all a bit messy in there, so we'll definitely do a next surgery at Salford to make it just a bit safer, because I might be spending a bit more time with scar tissue and whatnot. So yeah, don't worry if you've got a band, you still can just be prepared that there's a little bit longer journey.
There's quite a few questions about excess skin as well, Jodie. So people are saying, can the surgeon predict, looking at you, how much excess skin you'll have? Have you got any idea kind of what people can do to help with it?
Yeah, it's really hard. So excess skin, the way it's going to be is down to 2 kind of things. One, how much weight you lose, which you can't really control that in terms of how your weight loss is. If you're doing everything right, it's coming off. But the amount of excess skin and how it looks is quite pronounced during that rapid weight loss. So you almost have to kind of say to yourself, I'm on a journey, I'm going through until I get to that year and a half to 2 years. You don't really know exactly how it's going to look, and your body does gobble it up a little bit as everything slows down, so it can look quite pronounced at first. However, how it looks is down to our own collagen and our own DNA structure. So some of us won't be as affected by it, and others will have much more pronounced excess skin. And obviously how high a BMI you come from, so the kind of heavier you are, do expect more excess skin. And there is, stick with our yearly medical weight management, because we have options to ask for apronectomies only. That's the only funded one we could sort of put in as a caveat with our plastic surgeons at Salford. So where people have got very pronounced debilitating aprons, once weight loss is maintained for a good 2 years and is, I think, at a BMI of 40 or below, our plastic surgeons can sometimes help, which is great. So yeah, so do be aware that just coming every year to that follow-up, you're always going to be aware of what else is out there and what's happening in the world of weight loss and what other things are there in terms of help you might need. So that follow-up's really important.
There's a few questions about gallbladder removal. Can it be done at the same time?
It can. Again, the surgeon will only ever want to do their primary surgery. So if a gallbladder is very problematic and flaring up all the time and just not nice and needs to come out, that would be your primary surgery, and then have a bariatric surgery. So yeah, we do have some people that are under general surgeons having gallbladder removals, and then some where the general surgeon will say, oh, they're so big, please could you do some weight loss surgery, and then we'll decide whether we do both together. But they rarely do that now, just because of the increased risks around infection and so on. So it's normally one and then the other, or depending on which need is greater.
Somebody asked about hair loss, Jodie, post-surgery. I don't think you touched on that today.
Yeah, so 1 in 10 patients can experience this. I need to see if I can find better data, because I actually find less than 1 in 10 in my follow-ups that seem to have it where we are up here. I don't know if it's something to do with the water, but we don't seem to have lots of this going on. But again, it's a stress response to surgery in the sense that you can't do anything about it. You can't prevent it. You can have all the biotin in the world. There's no point. We give you something called forcible, which has got everything in that biotin has anyway, and then some more. So in terms of the way that you can kind of prevent it and slow it down is following that kind of protein, that's 60 grams for ladies and 80 grams for men of protein in your kind of daily intake, and that will promote healthy weight loss. But when that rapid weight loss slows down, it will also help with any hair regrowth if you have suffered that. So you tend to have to get through that first sort of 4-month period and to then be like, oh great, okay, I'm noticing there's not hair coming out when I'm showering now, and then you might notice little owly tufty bits going through, and it may not be quite the same as it was before, but it should grow back, and it's all down to good protein intake.
Thanks, Jodie. Somebody has asked if the sessions are going to bi-monthly, when will the next session be?
So I think the next session I'm doing is going to be a patient experience night, so I'm merging the 2 groups, and I think that's next month.
The 5th.
But yeah, don't worry, we'll keep you posted on how the sessions are going to look, and then obviously Stevie and her team have just been so great because they've got all the archive of the videos for you to access, and I think that's through the closed Facebook group, isn't it?
Yeah, so
And
lots of people have
chats
joined
in here
it.
as well. Yeah.
Yeah, so what will happen when the sessions change dates? So Jodie and I will get together and we'll confirm when all the dates are, and I'll change the Zoom invitation, so it'll change the dates and you'll know in advance when they come. So you tend to get, when you sign up or you register, you'll know you'll get a personal link to join the session, which is how we know that you've attended along with your survey. And you get a reminder the day before and an hour before the session. So you'll know when they're coming, you will get those reminders, and they are by email. But it'll also be kind of on the long list that comes through when I update them. So we'll do that as soon as possible, won't we, Jodie?
Yeah, definitely.
One question I wanted to ask Jodie was, last month, Mr. Alkafaf said he would answer some questions that weren't managed to be answered during the session, and I sent them to him. I've not managed to speak to him. Do you know how he's getting on with them? I imagine he's a very, very busy man. So
yeah, of course. I will ask him for sure. But don't worry, I'll be tracking down another one of our surgeons to come and talk. So if there's anything else, he can always pass them on if he's not had a chance. But I'm
he
sure
did volunteer though. I'm not sure why he did that. Crazy.
He's really vigilant. So if he said he's going to do something, it probably is or has happened. So yeah, don't worry, watch that space. Thank you so much for everyone who's hung on listening to me for this amount of time. It's really great for giving you time this evening, and I hope things go really well for you with your weight management services, and that I get to meet you properly in the future. Take care now.
Thanks everyone. Have a lovely day. Bye, Jodie.
Thanks, Stevie. Bye now.